And I see Dr. Norquist popping up on our screen.
Hey there, Ken.
Dr. Norquist is currently an associate professor and associate residency program director at the Department of Emergency Medicine at Texas Tech University Health Sciences Center in El Paso. Studied medicine at the University of Chicago, then completed residency in Cook County, a true knife and gun club. And then following residency, served at faculty at Cook County. His academic interests include medical education and airway management, and he served as the chair of the Airway Interest Group for the SAEM Association, and he's also co-editor of the book entitled Atlas of Clinical Emergency Medicine. Most importantly, he is a fellow North Dakotan. So what's up there, eh? It's good to see you.
That's funny. I'm having to trade in my quasi-Canadian accent for a Texas accent these days.
I've done this. Yeah.
But no, thank you for the invitation, Ken. It's been great joining you all the past 2 days, making new friends virtually. I've been able to listen to everybody else. You guys have all done a fantastic job, and I hope to play my part in this interesting conference. So as Ken stated, and Dr. Wells, I am currently practicing in El Paso, Texas, and it really is a unique place to practice medicine, as we are the largest city on the border between the U.S. and Mexico. So this is a shot including El Paso and our sister city of Juarez, Mexico in the background. And so it really is a cool place to practice medicine, an amazing patient population, and some really interesting pathology. And so this is, again, a bit of a broader scope of our region, including the Southwest and most of Texas. And on this map, I included 11 of the top 20 cities most affected by COVID on a per capita basis. This is according to the New York Times data. So in El Paso and the border and Southwest US, we certainly have seen a lot of COVID. And in fact, El Paso is number 5 on the per capita list for most affected cities. And as Ken stated, I'm a native North Dakotan, and just by happenstance, Bismarck, North Dakota, my hometown, just narrowly beats El Paso as being a bit more effective. So I have a strong connection to 2 of the top 5. This was our COVID curve here in El Paso, and you can see our peak. It seemed like every region of the U.S. peaked at a little bit different time. We started our peak in early October as far as the daily case rate really starting to pick up, and it peaked sort of in mid-November. And as we all know, when the patients start getting sick with COVID, they start flooding into your emergency department with severe COVID ARDS, and require intensive care in our hospital. And so as you can see, in November and December, we were very much overwhelmed as a hospital system. I'm super proud of our department, ICU. We all really came together to try to optimize care for our patients. And it was during these 2 months that our chairman reached out to the critical care unit and basically offered us, we carved out a piece of our emergency department to make an ED-based COVID ICU. And our chair asked me if I would lead up that group. And so most of my time in the months of November and December were spent not as an emergency physician, but as a moonlighting critical care physician. I am not board certified. I have a little bit of a complex following Dr. Sithala's a wonderful lecture, but I think my goal in talking to you today is to share some of my experiences as an emergency medicine generalist who was asked to step up and provide critical care to COVID patients, and focusing on 3 questions that surround airway management with COVID patients. And as I kind of introduced our practice environment, it is a bit unique. El Paso really is an island. There's nothing for hundreds of miles. All we have is Chihuahuan Desert. And so we are sort of a mix. We have a lot of folks in the conference here who are rural and certainly very resource limited. We had some presenters who were at really quaternary care institutions that have ECMO and basically anything under the sun. We're somewhere in the middle. We have a good amount of services, but we lack some things too. And so hopefully I can share some of my experiences and you can learn from me. So Dr. Sithala went into this a little bit on when to intubate. So I'll just build on some of the points that he already brought up. And again, he introduced this controversy that was primarily during the beginning of the pandemic when folks were following this early intubation strategy. And locally in El Paso, a lot of this controversy had played out prior to when we hit our peak. Early in the pandemic, when we'd admit COVID patients to the ICU and they had lots of resources because they weren't overwhelmed, I think people tended to be intubated a little bit early. But as the rest of the world moved away from that, we certainly were on board with high flow nasal cannula and prone positioning and just kind of more of a wait and see approach. However, when our ICU got overwhelmed pretty quickly, we were trying to manage patients as much as possible without putting them on the ventilator. And that was a big challenge for me, just personally. Dr. Sathala talked about some of the patient-induced lung injury that I was concerned about with tachypnic patients, and then also concerned with people. We did have to use some non-invasive ventilation, concerned about the level of tidal volumes that they were taking on that. So it really was a challenge. As priorly presented in the previous talk, these are the published reasons to intubate somebody with COVID, which is just in line with what we do for any hypoxic patient. But really deciding when the worsening hypoxemia crossed some threshold, or when increasing respiratory distress crossed some threshold to require intubation, I think is a challenge and continues to be a challenge. When I would follow these patients for days on end, oftentimes they looked pretty good and they were refusing intubation. And so I think we really had a dearth of information guiding best practices. This is a recent publication that I wanted to highlight that I do think informs that decision a bit. This was a recent publication just in March of this past year. So information was not available to me back at the end of 2020. But what these authors did is they did a systematic review, a meta-analysis of several different cohort studies. And basically, they were just looking at timing of intubation and looking at its ultimate outcome as far as mortality. And you can see here that the time of intubation, they separated them into an early intubation group, one that was intubated within the first 24 hours of ICU admission versus people who were intubated later during their ICU course. And they found no difference as opposed to as associated mortalities. Then they also looked at patients who underwent a trial of less invasive modes of ventilation, and they also found no difference in associated mortalities in patients who had a trial of non-invasive or high-flow nasal cannula versus those that did not. And I still think there's lots of questions remaining. I know there's lots of investigation into continued guidance as far as the best time to intubate these patients. But really, when you think back to just typical ARDS, I don't think it's always clear when is the optimal time to intubate. And so these decisions I think will continue to be made on a case-by-case basis at the bedside. Moving on to how to intubate, Dr. Sathala briefly talked about his approach for the actual intubation. What I wanted to focus more on is the pre-oxygenation, the phase that we all do to prepare our patients for intubation to avoid peri-intubation arrest. We all know that hypoxemia is one of the strongest predictors of a peri-intubation arrest. And so this controversy, I think, is less germane today than it was, say, 4 to 6 months ago. Dr. Klompus gave an excellent talk yesterday where he spoke of some of the concerns with healthcare associated transmission of virus, and that it appears that most healthcare workers actually did not get COVID when they were at work in the ICU. And he had a great graphic that showed that folks who are in the ICU typically have the inflammatory stage of the disease, and that they're actually relatively non-infectious by that point. And it was interesting. We talked about this a lot on shift, in that I had just a sense that they must not be that infectious, because despite trying to apply all sorts of safety measures, I'd have to be honest, we were actually responding to codes up on the floor, intubating people nearly every day. And I was basically there 6 days a week, and, I never got sick. Nobody else on the team got sick. So I felt like there must be some diminished infectiousness in these patients. And the data is now showing that out. But we wanted to provide optimal conditions to our patients, and not just do the strategy that some places were doing, which was to put them on a non-rebreather and just do your best. And, I have a huge debt of gratitude to many of the giants in our field, the names that you all know, who did so much to inform not only our specialty, but other specialties on how to prepare ourselves for COVID patients. And I think we were very well prepared. We had a good strategy to help support these people during the fractionation phase. I first saw it on Scott Weingart's MCRIT site. And that's the approach I wanted to share with you, because I think not only does it inform our management of COVID patients, but it also informs our management of any hypoxic patient. So we got fairly resource limited. We started to run out of all sorts of equipment, but the setup is quite easy, nothing fancy, and it can easily be applied in a few short minutes and is quite portable. So we were able to take this up with us when we were responding to codes on the floor. Basically, all you need is some form of solid mask. We typically used the bag valve mask you see on the left. We started to run out of our solid non-invasive ventilator masks that you see on the right. Just need some sort of bag valve mask, which we all have. But what you need is the PEEP valve, which are becoming more and more readily available. We would typically set it at 10 centimeters of water pressure, and then a viral filter, which we all used. But the key is you need to have some sort of post-stem source of oxygen, so you're charging that PEEP valve so that it is actually applying the PEEP that you have when you apply it to your patient. And that I think most folks don't necessarily know inherently. I don't think that was well taught to me. These are the different options that were demonstrated on the MCRIT site in order to entrain some additional source of oxygen posterior to that stem. We typically use the nasal cannula set at 6 liters a minute. And it was because we just ran out of end-tidal CO2 detectors. We were running short on them. And so the nasal cannula was easy. So we'd apply that to the patient. Here's that equipment setup just all together, pretty simple. And here it is applied to a simulated patient. You see we have the 6 liters nasal cannula applied. We have a nice tight mask seal with our viral filter in place with our PEEP valve at 10. And so as opposed to a non-rebreather mask, which applies about 70% FiO2. With this, you're able to get close to 100%, but more importantly, you're able to apply some PEEP during that pre-oxygenating phase. And this worked great. We would get called up to codes, or ambulance would bring people in. We all took care of these people. They're in the 70s on non-rebreather. After several minutes of having this setup applied, most patients, we were able to improve their work of breathing, and were able to support their oxygen into generally the high 80s or low 90s prior to our intubation attempt. So that's what we did for pre-oxygenation. As far as apneic oxygenation, most airway societies were recommending against apneic oxygenation for concern for aerosolization, which again, that concern is much less today, but we used the same setup for our apneic oxygenation. After we pushed our RSI meds, we just gave a good, nice jaw thrust. We already had a tight mask seal in place. And here we're able to provide that PEEP, so those alveoli are staying open, so we're continuing to have some oxygenation during the apneic phase. And that was, of course, to support them and hopefully avoid precipitous desaturations. Then moving on to mask ventilation during your apneic phase. We tried to avoid this, which was in line with what most airway societies were recommending. But again, as you can see, if you have the same setup in place with a nice tight mask seal with their viral filter in place, a good jaw thrust opening that airway with good gentle bag valve compression, you're not going to exude virus into the air. And so again, this worked really quite well. And I just wanted to just take a couple minutes to just sort of share that with you, because we really did have good success with this. Because you can see it's just the same simple setup, flows nicely from pre-oxygenation into apneic oxygenation and into manual ventilation. Hopefully we are on the back end of the COVID pandemic, but like I said, the same setup works well for any severely hypoxic patient. And again, I don't want to be pessimistic, but who knows what the future will bring. So this is just another tool to keep around for when you might need it for future pandemics. Okay, so lastly, it was how to ventilate. And so Dr. Sithala was on this topic when he was called away to take care of that critically ill patient. And I was interested to hear what his approach was, but I wanted to share our approach with you about how we ventilated our patients. There was a lot of controversy about this topic during the pandemic. It really started early, I'd say early 2020, when the world famous critical care anesthesiologist, Dr. Gattinoni from Italy, started publishing some case reports indicating that patients he was seeing in Italy didn't have the typical ARDS physiology that he was used to seeing. And he was proposing using alternative ventilator strategies, using more liberal tidal volumes, more limited PEEP, and more liberal FiO2. He got a lot of backlash from the rest of the medical community who stated, we just can't abandon everything that we've typically done just because this is a new novel condition. But there was a lot of discussion about the best way to ventilate patients. And so as I was deciding what the best strategy for us was going to be, I really went back and wanted to look at where this strategy came from. So this is the lung protective strategy that is drilled into the minds of all interns during their ICU rotations. It's a combination of low tidal volumes, low plateau pressures, and relatively high PEEP levels using a PEEP table. And where did that come from? So it really came from the ARDSNet trial that we all hear people throw around a lot, otherwise known as the ARMA trial. I don't know about y'all, but back in 2000, I wasn't in a position to be reading the New England Journal of Medicine, so I never read this article. I certainly had a lot more hair then than I do now. And those of you that maybe were practicing in 2000 and did read this article, it's been a long time since you probably read it, and so people forget what it actually studied. So a lot of times things are attributed to literature that actually maybe isn't appropriate. And so what did the ARMA trial look at? Their goal, their outcome objective was to compare two different methods of ventilating. So they compared using low tidal volumes versus standard, and then using low plateau pressures versus standard. What it did not do is it didn't look at optimal PEEP levels or optimal FiO2 PEEP combinations. That wasn't what this trial was designed to do. And in fact, several trials after the ARDSNet trial sought to determine optimal PEEP FiO2 levels. However, none of them were able to definitively answer the question. Basically, all we were left with was the knowledge that low tidal volumes are good, low plateau pressures are good. However, the ideal level of PEEP and FiO2 combinations was not entirely clear. When we're ventilating an ARDS patient, we want to avoid the zone of atelectasis and the zone of overdistension. So again, remember, the zone of atelectasis is if you have insufficient PEEP, with every breath, with every tidal volume, the alveoli are being forced open and then they collapse. So this continuing opening and closing leads to atelectic trauma and lung injury, which is deleterious to your patient. If we overdistend our patient with excessive PEEP, then we move into the zone of overdistension where pressures are high. And with every tidal volume we give our patient, we're overdistending the alveoli to squeeze in that tidal volume. And the patient suffers lung injury through barotrauma and volutrauma. What we really want is this safe window where the alveoli are open, however, they're not being overdistended. And some people have hypothesized, how does a PEEP FiO2 table help you find that safe window? And some would argue that maybe it doesn't. Maybe there's a better way. So this, the Amato trial was published in 2015. And this was also a very important trial that I think sometimes in the emergency department, we haven't played it as much attention as it deserves. And so the authors led by Dr. Amato hypothesized that the driving pressure would be a significant importance for survival in our ARDS. So driving pressure is the tidal volume divided by the compliance of the respiratory system, which can be easily calculated at the bedside by subtracting the PEEP from the plateau pressure. So here's the data from the study. And as you can see here, that they had three different subsamples that they included. So they reviewed, they did a meta-analysis of many randomized controlled trials that looked at ventilation. So what they did is they in their first subset, they kept the PEEP constant. And then so they classified patients by increasing plateau pressures with increasing driving pressures. And what they found is that there was increasing mortality. And then they grouped their patients by having, they kept the driving pressure constant and thus then grouped them by increasing plateau pressures with increasing PEEPs, and they found no change in mortality. And lastly, they grouped the patients by keeping the plateau pressures constant. And then what that did is then that kept the PEEP increasing. The PEEP was increasing with decreasing plateau pressures. And what they found then was that in that case, they had decreasing mortality. So overall, what was notable about the study is that they found is that so we generally think as higher plateau pressures as being deleterious, as being bad. But in this data set, it was not noted to be always risky. And higher PEEPs generally are considered to be protective in ARDS. However, again, looking at the data in this way, it did not seem that it was always protective. I think, so that was the first major trial that really looked at this. I think this follow-up trial actually makes this a little bit simpler and is able to interpret the results. So this was the Siesta group that looked at driving pressure and patient mortality. And they also reviewed randomized control trials of patients who received lung protective ventilation in ARDS. And what they found was that driving pressures were associated with an increased risk of death in the hospital. And here they looked at the data in a different way. So here they noted that patients who had high plateau pressures always did poorly, and that's consistent with the ARDSNet trial, so that makes sense. However, a low plateau pressure was only protective if it was paired with a low driving pressure. And here, higher driving pressures were always deleterious, leading to were associated with high mortalities. However, low driving pressures were only associated with good outcomes if they were also paired with low plateau pressures. So from this data, it appears that not only is low tidal volumes important, low plateau pressures are important, but it also appears that keeping your driving pressure low is important. And today, most experts recommend keeping your driving pressure under 15. So here's a way that you can use driving pressure to bring it to the bedside and see if you're ventilating your patient appropriately. So just for example, here I set a patient PEEP at 5, and the patient is undergoing atelectasis, and that's bad. So we check the plateau pressure, that's 23, and that's under 30, so it seems like they're appropriate. However, if you calculate the driving pressure of 18, that's higher than 15, so that's too high. So this would give me some information that I need to increase my PEEP. And here, if I've over-distended my patient with excessive PEEP, here I check a plateau pressure, it's 29, and the driving pressure is 17, which again is too high. So this is going to give me some information to decrease my PEEP. And again, here I'm with my alveoli that are nice and open, but not over-distended. I have a PEEP of 10 with a plateau pressure of 24, and that gives me a driving pressure of 14, which is acceptable. So here's an example of how I applied this at the bedside in a patient with COVID ARDS. So after intubation, the patient's PEEP was set at 8. I checked a plateau pressure, which gave me a driving pressure of 17, which is too high. So I suspected that I was under distending my patient. So I increased the PEEP to 10. Plateau pressure went up to 26, which gave me a driving pressure of 16, which was improved, but still not at goal. So I increased my PEEP to 12. Plateau pressure of 26, which gave me a driving pressure of 14, which is at goal, but again, the lower the better. So I felt a little greedy. I increased the PEEP to 14, which the plateau pressure shot up to 31, perhaps giving me some information that I've over-distended my patient because I had a driving pressure that's too high. So I ultimately went back to a PEEP of 12. So this has been how lung protective strategy is presented, but more and more people are arguing that instead of just blindly saying we should use a high PEEP, that perhaps we should optimize the PEEP to our patients who have ARDS with a goal to keep their driving pressure under 15. And that's really the strategy that we adopted. So after intubation, we would set the tidal volume. We try to get tidal volume to 6 mLs per kg, try to ensure that the plateau pressure was under 30, which generally for COVID ARDS was not a problem. We'd optimize the PEEP, and then we would play with our FiO2 to get them to the desired oxygen concentration. But how did the rest of the world do it? Again, I felt sort of as I was carrying a baton for emergency medicine, I really wanted to do a good job when I was taking care of these patients, not just from a personal level, but from a professional level too. And so this was also published in just March of this year. And these authors did a review article that just described how the rest of how different studies published showed how they were ventilating their patients. So in general, their ventilator settings were consistent with our strategy: tidal volumes of 6, plateau pressures under 30, optimizing the PEEP, kind of moderate levels of PEEP, but keeping in mind to keep the plateau pressure under 15, and then using FiO2 and respiratory rates according to patient needs, which again was consistent with what we were doing when we were managing patients in our emergency department-based COVID ICU. So these are the 3 questions that tormented me for 2 months, and I continue to be very interested in the absolute correct answer to these questions. But ultimately, I think the more we've learned about COVID, the more we've learned is that it's less about COVID and maybe more about just providing high quality critical care to our patients so that we can provide them with excellent care. And with that, I'd like to thank you again for the opportunity to come and join and share with you all my experiences. Thank you.
Dr. Norquist, thank you so much. That's already practice changing to me to bring the concept of driving pressure to the bedside. Most certainly, I was just a PEEP guy, ARSNet, and looking up the table. That'd be it. Or more importantly, if we had respiratory therapy, I'd be like, hey, put them on ARSNet and then figure everything out for me. Would probably be more appropriate of what my practice style is. So that's amazing. Thank you. Second, I would also say, carrying the banner for emergency medicine, we are ambassadors for our specialty, which is still relatively young in the scope of all of medicine, and completely agree that we sort of branch and bring together a lot of medical specialties, from bringing a generalist and unscheduled primary care to specific emergency department care and trauma resuscitation, and now, since we've been boarding a lot of these patients, to critical care. And that's what we focus on. Rather than focusing on one particular condition, we focus on a very broad view and scope of skills and specialties that we need to be experts in. And we need to really demonstrate the value of our profession. So thank you for bringing in that research and for me, that new paradigm of ventilating and managing ventilated patients. So thank you. Sean, do you have anything else to add?
No, I just wanted to echo those comments, and for really helping us as emergency providers and as ambassadors of emergency medicine, really kind of lead the charge in getting this critical care right. And for this audience in particular, we live in that space in between the ED dispo and the prolonged care and the mini ICU in our EDs. We've heard a couple times today for 12, 24 hours that we're taking care of this patient. So it really behooves us all to have a strong handle on what you've shared today. And I just want to add to Ken's thanks. Really appreciate it.
Of course, my pleasure.
And team, we're almost at the end of our day, and thank you guys so much again for a wonderful and informative and practice-changing clinical didactic session of the 3rd annual conference.